So as I mentioned, we have speakers who are amazing. They're experts in their own rights, but I will try and do a little bit of justice into who they are. Of course, I'm Lizzie Otai, and I'm the communications consultant for ENASO. And welcome and thank you very much for sparing your next 1.5 hours. So we're going to have Dr. Anouk Govera, who's Director of Communication and Programs from GSA. She has a PhD from Imperial College London, postdoctoral research on schistosomiasis at the Natural History Museum since 2017, and she ensures that GSA serves as the enabling, coordinating, and leading platform for the schistosomiasis community. 1 minute, please. Sorry about that. So that's the first speaker. Then we have Leora Pile, who is the FIG co-chair. We'll know more about what FIG does. And she's lead HIV prevention advocacy, Frontline AIDS UK, and background in HIV prevention for adolescent girls and young women and key populations. Ladies and gentlemen, as I mentioned, there's a lot of information and background about the guests, but this is just a snippet of their CVs, which are pretty heavy, that I'm trying to read real quick because of time. Now, for Leora, she holds a master's in international relations and gender, HIV and SRHR programs and advocacy experience in South Africa, Kenya, Malawi, Uganda, Zimbabwe, Tanzania, Eswatini, Nigeria, Angola, and India. It's quite a mouthful, but welcome very much, Leola, and thank you for joining. Then we do have Dr. Victoria Gamba. Now, she's an independent consultant specializing in integrated healthcare training and diagnostic needs for women and girls, a leader in empowering healthcare professionals in Kenya to integrate service delivery for obstetric care and newborn care, family planning, post-abortion care, and female genital schistosomiasis. Karibu sana, Dr. Victoria Gamba. We also have Simon Sikwese, who is the executive director of the Pakachere in Malawi. Pakachere runs multiple HIV prevention and sexual reproductive health and rights programs, a leading partner in public health. He's a passionate public health expert with over 20 years of experience and holds a master's degree in public health. We also have Yale, and a background of Yale from the UK is that she has expertise in WASH for health and public health policy, holds a master's in health policy, planning, and financing from the London School of Hygiene and Tropical Medicine, and program experiences in Uganda, Nepal, and Nicaragua. Now, ladies and gentlemen, we also have Alia Amini, who's a Moroccan health activist working since 2017 in the fight against HIV, TB, and malaria. She's passionate about advocating for access to health for all, and especially women and girls in all their diversity. Alia was the MENA Regional Global Fund platform. And I know, ladies and gentlemen, most of you have actually dealt directly or indirectly with Alia and her capacity under the MENA Regional Learning Hub. And is now working as the gender advocacy lead for Women for Global Fund. I know this panel looks like it's women-centered and women-heavy, but this is because FGS does affect a lot of women and young girls, and that's the reason why we're having all these discussions today. So, next slide, please. Without much ado, because as I mentioned, it's only an hour, 20 minutes, I'm going to call out the speakers. And I believe we're starting with Dr. Anouk. Dr. Anouk, if you're in the room, please just unmute. There you are. Great. And take us through the first presentation. Thank you very much.
Thank you so much for the warm introduction and for organizing and hosting this webinar on a much needed and underrepresented issue for women's health. This topic is very dear to my heart, and I hope that by the end of this webinar, if not already, it will be very dear to your hearts too. We at the Global Schistosomiasis Alliance, a network of organizations, research groups, and stakeholders working on schistosomiasis, have a vision of a world free of this insidious, hidden, and damaging disease. And in Africa, the mainstay of schistosomiasis control has been through school-based deworming programs, which have made significant gains in reducing infections and improving health. And perhaps to share some good news, which we could all use these days, much progress has been made in reducing the prevalence of schistosomiasis by almost 60% over the past 2 decades, thanks to the dedication of governments, charities, companies, private, public, and multilateral organizations. However, we know that we are not reaching all those in need of treatment, in particular, girls and women living in rural areas who are underserved by health, water, and sanitation services, and those who are marginalized and most vulnerable. In 2022, the WHO released a policy paper on the need of deworming programs to reach adolescent girls and women of reproductive age as a priority group, recognizing that currently we are failing to reach them. We also know that to meet their needs, to improve health outcomes, and to achieve our own vision of schistosomiasis elimination, we need to work in partnerships outside our own sector and area of expertise. So we are very proud to be part of the Female Genital Schistosomiasis Integration Group, FIG for short, who have co-organized this webinar with ENSO and Women for Global Fund. Thank you so much. Perhaps if we move to the next slide, please. Oh, well, Lizzie has already done this in such a great way. So let's move perhaps to the next slide. Thank you. So perhaps something to think about as we hear from experts on FGS, sexual reproductive health, and HIV prevention is, what do we mean by ending the neglect? What or whom is being neglected and by whom? Today you will hear about FGS. This is not a new gynecological issue. In fact, we have known about it since the 1950s, but that knowledge remained locked in the sphere of academia. Doctors weren't taught about it, healthcare professionals didn't know about it, even the people and communities most affected hadn't heard about FGS. And yet an estimated 56 million women and girls in sub-Saharan Africa may be affected. So we can ask, is this a neglected condition? Or is it about our neglect of these girls and women living in underserved areas? Many women and girls carry a triple burden of vulnerability to HIV, HPV cervical cancer, and female genital schistosomiasis. And there is mounting evidence of a three-way interaction between these diseases, in addition to important implications for STIs and sexual reproductive health and rights, so that we can infer that controlling one of these diseases may decrease the risk of unwanted outcomes for the others. All these programs have been delivered for decades now, and yet we have not reached our agenda targets, largely due to this siloed, disease-focused approach where we systematically focus on numbers rather than people and their needs. If we go to the next slide. So I just wanted to highlight this as an example. On the left is a figure taken from the UNAIDS report 2024, which highlighted that in sub-Saharan Africa, there is a serious HIV epidemic amongst adolescent girls and young women. In fact, 4,000 adolescent girls and young women a week become infected with HIV. That's 4,000 girls and women a week. Consider now that having FGS increases a woman's risk to HIV threefold, and look at the map on the right from the WHO showing the endemicity of schistosomiasis in sub-Saharan Africa. And consider that both these disease-specific programs want to reach the same adolescent girls and young women. Next slide, please. So just to wrap up, we all recognize that we need to move beyond disease-focused models. Working together, we can move to meeting the health needs of women and girls. This has been emphasized by WHO and UNAIDS in their No More Neglect report and call to action, and in the UNAIDS Global AIDS Strategy. we are all part of the same agenda. We want to deliver comprehensive, equitable, quality health services for women and girls. This will galvanize progress and help us reach our respective goals. I am very excited to be here with you, to learn from you, and to discuss ways we can transform our approach, our reach, and our health through partnerships. Thank you very much, and over to you, Lizzie.
Thank you very much, Doc. And I think you really literally brought it back home. And I know the other presenters are going to literally like dissect it so that we know more. But what I like is the fact that you've called for collaboration, and it's high time we look at people and note numbers, but the numbers also help in understanding that, you know, there's an issue here, it hasn't been addressed, and it's high time we give it all the attention that it deserves. So ladies and gentlemen, I do have my colleague on the call with us. Richard is going to help us just do the first poll. We want to kind of get a sense of people who are in the room and if they do understand what the discussions are all about. So this is just a first round of questions, and we'd want you to just, you know, respond to it. Thank you very much for people who've already done that so that we can carry on with the discussion. We want to have a feel. We want to know who's in the room, which countries are here, etc. I know the chat function was disabled, but I'm hoping it's all clear and working now. I can see there's some chats coming in. So thank you very much. Feel free to introduce yourself. We're all about networking and collaboration. And thank you very much, Doc, for you calling out that is one of the main areas that we need to work on. It's high time that we give FGS the limelight and the time that it deserves. So thank you, ladies and gentlemen. We appreciate it. I know we have more than 100 people on this call. We've seen 47, 49, half of them actually already giving in their feedback. We also want to know, have you ever had about FGS before this particular webinar? And we've been given a breakdown of what that is, but of course the other speakers coming in will also shed more light on what this is all about. But as the polls are going on, before we close that, I know the next speaker is Leora, and Leora is going to also take up the discussion from where Doc has kind of left off. And we're going to talk about FGS 101. And I know a lot of people have actually given their input on whether they've had about FGS before or this is the first time. And yeah, it looks like a lot of people have had of it. And this is good. Thank you very much for being part of this first round of poll. And we'll go back to the presentation, Richard, because we only have short enough time. We'll just give it another 30 seconds for people to let us know where they're joining in from and also whether you've ever had of FGS before this particular discussion that we are hosting. Great. Leora, I know the slides are still being shared.
Yes. So I'm actually going to hand over to Dr. Victoria Gamba, who's going to present around FGS 101, and then I will take over from her. So Dr. Gamba, do you want to go ahead?
Yes, please. Thank you, Leora. Thank you, team. Thank you, everyone, for joining. I'm very happy with the introduction from the team. Lizzie, Dr. Anouk, you've really introduced the subject very well. And I think I want to go straight into what is female genital schistosomiasis. And basically, that's why we're here. We're trying to gain more awareness about this. And in the end, once we develop the knowledge, we will be able to now do or act on it, because it is enough to know, but the next step is, what are you doing about this? So female genital schistosomiasis is a chronic infection that is caused by a parasitic worm known as Schistosoma hematobium. And as has been said by the WHO, it is estimated that almost 56 million women are affected by female genital schistosomiasis in Africa. The symptoms can vary, but they do come about when the parasite's eggs are deposited in the reproductive tract, often leading to inflammation. And as we know, the female reproductive tract is composed of the ovaries, the fallopian tubes, come to the uterus, then you have the cervix and the vagina, and then now the external genitalia, which is the vulva. So why are we focusing now a lot on women and girls? We've seen the disproportionate affection that they have. They're affected by FGS, basically as they're undergoing their daily routine activities. And as you have seen, even with the UNAIDS, statistics that they've given us about the 4,000 women and girls who are affected by HIV infection every week, 78% of these women are actually in Africa, which means there's probably something ongoing and we need to investigate deeper to see actually what exactly are these issues that are making them become or exposed to HIV or developing all these other complications, as we'll see as we go along. So the main treatment for female genital schistosomiasis, which is a morbidity assessment, I'm really hoping there's not too much, what is it called? There's a lot of disruption. Sorry about that. So the mainstay treatment is actually with praziquantel, and we will talk more about it in terms of how it responds to the medication itself, and the prevention strategies that have been in place is still with the use of praziquantel. We can move to the next slide. Yeah. So the symptoms, as we've said, will vary depending on where it is affected, but majority of the time, as with any cause of infection that affects the reproductive tract, once inflammation is there, pain is often the resultant effect that comes about. Then you can have abnormal discharge, you can have bleeding, whether it's during intercourse or after intercourse. You can also have that discomfort or pain during or after intercourse itself also. You can also have low abdominal pain. Majority of the time, some of the symptoms are very difficult to differentiate from sexually transmittable infections. And that means in the whole range, it typically presents just as a reproductive tract infections. And the onus is always on the physician to try and differentiate what exactly is the cause for all these genital symptoms. That said, if the physician is not aware or does not know about female genital schistosomiasis, it is likely that these women will leave that hospital or that facility without getting the actual treatment for the cause of all these genital symptoms that they have. So what happens when that diagnosis is missed at this point? They often continue having these inflammatory reactions, granuloma formation, leading to now this irreversible damage that happens in their genital tract. And some of the things that we have been able to see is, having a miscarriage or an ectopic pregnancy, depending on where the inflammation and fibrosis has happened, especially in the fallopian tubes. Same way, if the fallopian tubes are blocked, it means now there won't be fertilization. So infertility becomes another complication that happens. So as we've said, unfortunately, once that fibrosis has continued for a very long time, reversing this tissue damage becomes very difficult. And most of the time, as you have seen, we always miss this diagnosis from the word go. So aside from the tissue damage and the long-term effect, these women will keep coming to the facility. They will keep being given antibiotics from time to time for symptoms that do not resolve. So that means it will also have other complications leading to more mental stress. And at times you can imagine if you keep going to the hospital for, genital tract issues, majority of the time it brings about an issue or suggesting that there's some kind of someone was either there's mistrust that actually comes about in the marriage. So that means sometimes it can also lead to intimate partner violence. So there's so many issues around this beyond just the genital tract. And I think it's high time we start seeing and high time we also start including FGS into the system so that we are able to diagnose it and give the actual treatment that it requires. So next slide. So when we talk about the triple threat that we are looking at, and I'm happy we are now starting to see more and more studies that are showing us, this kind of interrelationship between FGS, HIV, and cervical cancer. We have various studies that have shown the association of HIV and acquisition of rather HIV when you have female genital schistosomiasis that is increased up to 3 to 4 times. And most of the time, all this is basically because of is the immunological barrier that is broken, as well as the physical barrier that is broken. So that means there's a lot of things that are ongoing that are predisposing these women and girls to HIV and AIDS. And that said, we all know that HIV increases your risk of getting cervical cancer up to 6 times. So that means from the start, these women are actually disadvantaged from the start. And if you're even to go further into those statistics of those 4,000 women who get HIV and AIDS every week, 1,900 of them are actually girls between the age of 10 to 19. So what does that tell us? We need to do something and we need to act now. So I think I will leave it here. I think I've talked about the antimicrobial resistance on and on. So I think I'll leave it to the next person to now lead you on the next step. Thank you.
Thank you very much, Dr. Gamba. And that was quite interesting. A lot of information that, whilst when you were talking, I was like, okay, now I can connect one and put those together. And it's something that's really close to home. But it's amazing how something like this, which is very serious and affects a lot of women and young girls, still can get misdiagnosed. So it looks like there's a whole system where there's a flaw, and it's from the whole, clinical aspect, and getting the medical professionals also involved, because if they do misdiagnose, then that's a whole different ballgame, because we'll talk about being on antibiotics and rehabbing antibiotics. And now we're talking about antimicrobial resistance being a whole issue. So thank you very much, Dr. Gamba, for that. And I really appreciate you kind of letting us understand what FGS is. So this was FGS 101. And I think after Dr. Gamba, Leora, do I call you back in, or is it Yale?
Yes, it's me.
Yeah.
It's me.
Perfect. So over to you.
Next slide, please. Thank you. So as Dr. Gamba explained, the way we can see the amount of FGS in countries is through the burden of urogenital schistosomiasis. And this is a map of Malawi where you can see a huge amount of urogenital schistosomiasis, and you can see the red has a high prevalence and the pink is moderate prevalence, showing that there's a massive amount of this particular kind of schisto that causes FGS. And in the table on the left, you can see the millions and millions of women and girls that FGS affects in all of these countries. And this isn't even exhaustive across the African continent. If you don't see your country here, it's just because there wasn't space. But it's just to give you a gauge of the burden of this type of schistosomiasis, and obviously then the burden and risk that women and girls face around FGS and the related risks for HIV and HPV. Next slide, please. So you've heard a lot about, the devastating side effects, well, not really side effects, but symptoms of FGS, the overlap with HIV and HPV. And you may be thinking, why on earth is this not being addressed? If it's increasing risk of HIV infection threefold, it's increasing HPV and cervical cancer, and it's resulting in devastating sexual and reproductive health impact for women and girls. The reason for the lack of integration of FGS is just because there is no global normative guidelines, essentially. So the WHO has not yet developed guidance for countries to use to integrate FGS and to clinically diagnose FGS in women and girls. And as a result, there's a lack of knowledge and awareness in the healthcare system. Because healthcare workers are not aware of FGS, they're unable to diagnose FGS, they're unable to log diagnoses, and so we don't actually have a proper number of women and girls affected by FGS. And we also don't have healthcare workers that are aware of FGS. They are not trained on the symptoms, the overlaps with STIs, HIV, and HPV, and they're also not trained on how to diagnose FGS. And so because of that, there are no national guidelines in place. And this results in a lack of FGS service delivery. So we rely a lot on the amazing work that neglected tropical disease programs do to distribute treatment in mass treatment campaigns. But praziquantel, the treatment for FGS, is not available in public healthcare facilities. And because of the lack of information that healthcare workers have, we have a large amount of misdiagnosis. Despite the fact that we have documents from organizations like UNAIDS speaking about how we need to end the neglect of FGS, we still don't have this global guidance. And that makes it incredibly difficult to integrate. But in the next slide, we will highlight that there are some opportunities that we can use to integrate FGS and start advocating for FGS in countries. Next slide, please. So FGS affects the adolescent girls and young women, sex workers, and other female key populations that are either at risk of or living with HIV in schistosomiasis endemic areas. And these are the very same girls and women and key populations that programs like your Global Fund programs are reaching. And so that is an opportunity to integrate some degree of FGS information and services in these programs because we're reaching exactly the same people. And because of the overlap with STI symptoms and the way that FGS clinically presents and the way it needs to be diagnosed, FGS can easily be integrated into SRH and HIV interventions. Considering the state of the global health world now and the funding crisis we find ourselves in, it is even more important that we look at all risks related to HIV and HPV and we move towards integration. It is unethical to leave these women and girls and all of these populations with a risk this high and symptoms so difficult to live with and the possibility of stigma and discrimination when it can be integrated into the SRH interventions. FGS really does provide a practical model for achieving impact on health, education, economic empowerment, and gender equality. And it can also really increase the resilience and sustainability of health systems and communities if we just provide them with the information and arm them with the information they need to understand whether they have FGS or not. Next slide. So we really, we really do need all high quality and comprehensive HIV prevention services to include FGS work and FGS services. And we need to see FGS as a way of highlighting, which healthcare systems are failing women and girls. FGS can really be seen as an entry point for improving quality and holistic HIV prevention services and improving trust in and uptake of these services through the integration of FGS in HIV prevention services. Just to say that there are a lot of countries that have done this, and we're not going into significant detail on that. But we also thought it would be really important to explain who FIG is and what the work FIG is doing. And to do that, Lizzie, I hope it's okay, I'm going to hand over to Yale, who's just going to give a rundown on FIG and how FIG is really trying to work towards these opportunities that we've highlighted, really trying to get FGS integration onto high policy tables and conversations, etc. So Yale?
Oh, thank you, Leora. I think we're maybe in the wrong order. So maybe I will hand over to, sorry, Richard, let's go back to the Sorry. Let's go back to the Malawi slide. I'll hand over to Simon and then I
Yes.
come in after Simon.
Okay, no worries. Yes,
This
I
one,
think that
correct.
that's
Yeah,
okay, great.
thank you.
So
Over to
thank you. I
Simon.
think we'll go back to you later on. Simon, welcome. I think we'll just go back to Simon to go through the whole Malawi as a case study, and it's good to actually figure out what they're doing down there. So welcome, Simon Sikwase. I know you're already on this call. If you can just feel free to unmute or maybe have your video on if you're comfortable with that, and then you can go through the slides.
Okay, thank you very much, Liz, Leora, and all the previous speakers. This is Simon Sikwese from Malawi, and I'm glad to be the only male among the distinguished ladies who have been presenting on FGS. As much as it's a woman's issue, but I think even men, we need to be concerned because it's affecting our daughters, our wives, and everybody, because these are women who we send to do the various household chores, washing, bathing in the waters from the pictures that we have seen. I'm going to present to you on the FGS response in Malawi, focusing on how Malawi has navigated through to ensure that FGS is moving towards integration into HIV and sexual and reproductive health. If we could go to the next slide. The journey for FGS integration in Malawi has been successful because of an advocacy process that we followed, and thanks to Frontline AIDS and Limit Health, who we worked with to ensure that this is achieved. Because before we embarked on this journey, what we discovered was that as schistosomiasis is a neglected disease, likewise, FGS has also been neglected and was very less known among Malawians. We're talking about the communities and even the policymakers. Much as various studies have been conducted in Malawi on schistosomiasis, but also FGS, you see that findings have been disseminated, but not widely. And this has also affected the way Malawi has responded to FGS. And in Malawi, one of the funny things that we noted was that the neglected tropical disease department and the Department of HIV and AIDS and viral hepatitis are in the same campus, but they've never talked about FGS until this issue was brought to their attention that there's a potential for increased risk of HIV among women and girls if we don't address FGS. So our advocacy journey was basically to make sure that we bring FGS to the platform and bring out the evidence to show the link between FGS and the risk of HIV infection. During the time that we were conducting our advocacy, World Vision International was and is still the principal recipient of Global Fund. And our approach was to ensure that FGS is addressed within the Global Fund proposal that Malawi was then developing. That is the current round 8. So we consulted World Vision, National AIDS Commission, civil society organizations, but also involved researchers and gynecologists to provide the evidence. However, one thing that came out clear was that FGS was not in any of the policy documents in Malawi or the guideline documents in Malawi. So it was difficult for FGS to be included in any of the proposals or even in the national strategies, like in the National Strategic Plan for HIV and AIDS, because it could only go there if it is in the some of the guidelines. In this case, we're looking at the STI guidelines. So we upped our advocacy and contacted the Department of HIV and Viral Hepatitis, where through our researchers and gynecologists, I'm glad that I've seen that Dr. Seke Kayuni is there. He was very instrumental in Malawi in terms of providing the evidence about the prevalence of FGS and schistosomiasis in Malawi. And during that time, it's when we found an opportunity to utilize the process that was undergoing to integrate, to revise the STIs, where we pushed that FGS must also be included in the STI guidelines. Next slide. So based on that, and working with Unlimited Health and Frontline Aids, who supported tremendously, we had a session where the STI guidelines were being revised, where with our researchers and gynecologists, we looked at the barriers and opportunities that are there to integrate FGS into the STI guidelines, so that again we can see FGS being implemented within HIV and SRHR interventions. So some of the barriers to successful integration of FGS that we highlighted included that FGS was nowhere in the national policies and guidelines, and this was a very big gap that had to be addressed. In terms of diagnostic capacity, again, we had challenges as a country because looking at the colposcopy diagnosis, but also the capacity of nurses who are not allowed to conduct colposcopy was also a barrier. We also noted that FGS being something that was and is still new, the knowledge of healthcare workers on FGS was very, very limited. And because, as I said, it has been unknown. But also, if you look at the neglected tropical diseases, schistosomiasis, trachoma, and the rest, these are diseases that are neglected, and they have limited funding. As a result, it was also a big challenge to address FGS in terms of service delivery, awareness, but also advocacy. We also looked at existing opportunities, and if you have seen from the earlier presentation, you see that the manifestation of FGS can easily be aligned to such conditions like cervical cancer. So we have very big opportunities that we can take advantage so that within the provision of SRHR services, we can ensure that FGS is easily integrated. So during our meeting with the ministry and partners in trying to integrate FGS into the STI guidelines, it was easy because we looked at issues of how the STI guidelines are going to be addressing issues of cervical cancer, STIs, and then because FGS manifests itself as the other STIs and cervical cancer, then even the diagnosis itself would be easy because you are going to be using the same platform and the same procedures. And then finally, we looked at how we should also be looking at how do we make sure that praziquantel is readily available in the health facilities, because currently praziquantel is only available mostly during mass drug administration. And when people present for FGS or schistosomiasis, sometimes they don't find praziquantel. So we wanted to make sure that in our integration or ensuring that FGS is included in the STI guidelines, all these things must be addressed. And what made our process successful was that the evidence that was provided by the researchers and gynecologists and how the integration should look like enabled the ministry and partners to accept that the STI guidelines in Malawi must include FGS. And we were very successful in ensuring that our STI guidelines in Malawi includes FGS, which means in each of the national guidelines or strategic documents, then FGS is going to appear. The final slide. And then finally, what is happening now in Malawi based on this is that we have revised the syndromic management of STI guidelines where FGS is included. And we are waiting for the endorsement by the technical committee. This is a high-level committee from the senior health management committee. Once this has been approved, then we're going to move into orienting all healthcare workers, which will require a lot of trainings to make sure that there's integration of FGS during SRHR interventions. But also currently, we are lucky that we are working with the GIZ through the Department of Neglected Tropical Diseases to pilot an intervention of FGS in 2 selected districts. But the plan of which is under development, and we're hoping that after this quarter, GIZ and the ministry is going to come back to us so that we roll out this pilot project. But all this has been possible because of the intensive advocacy campaign that we implemented to make sure that we bring FGS into the limelight, and then those policymakers should appreciate the link between STIs and FGS. Thank you.
Thank you very much, Simon. And this is quite intriguing. I really do look forward to getting, just knowing the data that you're going to find and seeing whether this, after all this research and, producing a lot of data to back up the fact that FGS is an issue, whether it's the pilot tests are going to actually start, influencing policies and hoping that the guidelines will actually be revised, etc. So do keep us on the loop on this. I'll call back Yael. I know, Yael, you're supposed to go in and let us know what FIG is all about. I've seen a lot of interesting questions on what is going to happen. Next slide, please. Go back. One more slide. Yeah.
We have a slide
Yes,
missing.
yes.
Yeah.
Okay, so Yael, over
yeah,
to you so that we can get to know
not to
more
worry.
about. Yeah.
Sorry, there was a slide on FIG, but I'm not sure if you can locate it. But just briefly, to share that FIG is a coalition of the willing. We are a group of non-governmental organizations and researchers who are working to advocate for the inclusion of FGS in reproductive health services, HIV prevention services, screening for cervical cancer, etc., for the improvement of the lives of women and girls on the in the sub-Saharan African region. I think that, so Leora has just put into the chat a link to our website in which you will find a brand new FAQ document that will give you all the information that you need on FGS and a starting point with which to undertake advocacy in your context. And you will also be able to sign up to our newsletter so you can find out about the work that we're doing, and also get in touch with us if your organization is interested in joining FIG. We need all the partnership that we can get, which is a good opportunity also to hand over to Alia after the questions and answers. We've been privileged recently to collaborate more closely with the NSO, but also with Women for Global Fund to increase the pressure for including FGS in Global Fund grants. So I'll leave it at that and hand back over to Lizzie. Thank you.
Great. And what I like is the fact that we also saw at the first poll that a lot of people have heard about FGS, so we're safe. Ideally, it's the access to a lot of information and kind of the nitty-gritties and more content that's missing. And that's one of the reasons we're hosting this webinar in collaboration with FIG and Women for Global Fund, and of course another SHARP project that we're implementing. So we'll go to the next slide. And I'll ask my colleague Richard again, sorry for bothering you, to just kick us into the next poll. And the poll, ladies and gentlemen, is just for us to also collect data on the information that you have. And also just to get some feedback, because now we're getting into what the Women for Global Fund has done around FGS and getting some more insight on what we can do next. And a lot of people on the call are from CSOs and community groups, and for us to also start advocating around convincing organizations and funders like the Global Fund to integrate FGS into HIV interventions. We do need the evidence and we do need the data. And I appreciate very much, Simon, what you're doing in Malawi and also just presenting the facts that this is an issue. And I know very well Dr. Gamba highlighted that it's lack of knowledge, and Leora also just reiterated on that lack of knowledge is why FGS has not been given the time of day. But ladies and gentlemen, I think the second round of questions is on your screen. Please do let us know, do you think FGS integration is relevant to your context? What do you need from us to be able to advocate for FGS in your context? And what one action can you take? But we'll go to the next slide as the poll continues running on the back. Next slide, please. So that we can call and move into Women for Global Fund and get to learn what they do. So Alia, over to you. It's quite interesting just to know what you've been doing around FGS. Over to you, Alia.
Thank you so much, Lizzie, and thank you for inviting us to be part of this really important webinar to discuss this really critical but overlooked issue. And I'm really happy to see many advocates, experts, and community leaders coming together today to discuss this and address this gap. So as you all know, FGS is not just a neglected tropical disease, it's a gendered health issue that has profound implications for women in all their diversity, for their sexual and reproductive health. And despite its prevalence, like our colleagues at FIG showed us, it's still largely invisible in the global health strategies, and especially within the HIV prevention and treatment programs. So today, Women for Global Fund wanted to really explore with you how we can bridge this gap and integrate FGS into HIV programming, and to leverage the existing platforms and to advocate for more gender transformative approaches in the Global Fund process. So I will present to you, the importance of having gender assessments in your countries, advocating strategically within your country coordinating mechanism, which is the CCM, and also to make sure that we have sustainable funding, especially in the current global health landscape for FGS. So next slide, please. First, I would like to present the Women for Global Fund movement for the people who don't know us. So we are a global movement of women rights advocates to advance gender equality within the Global Fund programs. So we are working with women in all their diversity to ensure that the Global Fund programs are meeting the rights and needs of women and girls, and that women are participating meaningfully to decision-making processes, whether it is at a national, regional, or a global level, and to make sure that women's voice are influencing how the Global Fund investments are spent in the countries, and to make sure that communities are really benefiting from the Global Fund's grants. Next, please. So when I say women in all their diversity, means that we are supporting and welcoming women living with HIV, affected by TB and malaria. We have some mentorship programs where we work with transgender women, women who use drugs, women refugees and migrants. And we are welcoming anyone who wants to support our mission and advocate with us. Next, please. Next, I think we already talked about this. So first of all, when we decided to work on FGS, the idea was to think why we need to integrate FGS into HIV services. First is that the link between FGS and HIV is undeniable. So women and girls are affected by FGS are more susceptible to HIV transmissions. And also they are, I mean, both FGS and HIV are affecting women and girls in all these countries. They have some shared barriers like FGS in stigma and gender-based violence from women who are seeking health cares. Also, health systems often lack trained providers who can recognize and also treat FGS. And also there is, I mean, a gap in unlimited access to SRHR services. We also identified the opportunities, I mean, to leverage HIV services platforms to address FGS as a critical SRHR issue. Next, please. So the idea is to advocate to include FGS in the modular framework of the Global Fund. So what is the modular framework? It's actually a Global Fund document that provides the standards modules and interventions and activities, performance indicators to develop the funding requests during the preparation of the funding requests for all the countries. So it helps classifies the activities under some standardized categories and to ensure the alignments with the strategic priorities of the Global Fund. So the modular framework includes categories like HIV prevention, treatment, system strengthening, and care modules. And also it provides, I mean, the general structure to design the Global Fund supported programs. So Women for Global Fund is advocating to integrate FGS into HIV services under certain models like HIV testing and counseling, to include it also in the training healthcare provider modules to identify and manage FGS, and also, I mean, in all the prevention treatment of SRHR services. So to be able to advocate for the inclusion of FGS in the modular framework, we need, I mean, to know the process of the Global Fund and how it works. And women advocates need to know how to navigate actually the Global Fund processes. That's why we have produced a document called Navigating Gender Transformation for Grant Cycle 7, but that can be used also for grants, the next grant cycle. And it helps you identify the entry points in the Global Fund funding processes to integrate FGS as national priority. And also it provides practical strategies for women advocates to engage with the stakeholders, to conduct gender assessments, and to ensure that the funding proposals are really aligning with the gender-focused interventions and addressing the real needs of women, girls, and communities. So I invite you to look at on our website for this document, and also for information about how to include FGS in the Global Fund modular framework. Next slide, please. So the importance of gender assessments for FGS. So gender assessments were launched by UNAIDS in 2010 to better respond to the needs and uphold the rights of women and girls within HIV response. So it is a country level implementations, and they are really critical for evidence-informed planning and budgeting for gender transformative HIV response, because I mean, using this gender assessment, we can provide data on gender-related barriers that are hindering both HIV, SRHR services, and FGS. We can also highlight the unmet health needs of women and girls that are affected by FGS, and we can inform the national HIV response and ensure that I mean, gender equality is embedded in the funding request. So for women advocates, we need to really advocate to get the information if your country has a gender assessment, has conducted a gender assessment or not yet. If not, we need to advocate for gender assessment, because it will be a way to influence change and to include the FGS in the national strategic plans for your countries, as one of the HIV services. Also, women can also push for gender assessment to be conducted as part of the CCM discussions, either during country dialogues or during the preparation of the funding request, and to make sure that FGS is recognized as a key gender related issue in the Global Fund grant applications. Next slide, please. So once you have the information if there is a gender assessment in your country or not, and once you have conducted a gender assessment, you can lobby for the inclusion of FGS related interventions in the Global Fund concept notes and budget. You can also use these gender assessment reports to mobilize additional funding resources for FGS intervention, whether it is with the Global Fund or other international donors that might be interested in funding FGS. And also you can help to diffuse the gender assessment reports to other stakeholders in your countries, and to create more awareness about FGS preventions and treatment. Next slide, please. So some here we put some examples of FGS HIV integrated actions that we are advocating for. So we are advocating for more community-based education on FGS and to show its link with HIV, for more combined FGS and HIV prevention campaigns that are targeting specifically young women, and a multi-sectoral collaboration between SRHR, WASH, which is the water, sanitation, and hygiene, and the NTD, which are the neglected tropical diseases sectors, so that we really have this multi-sectoral collaborations and approach, and to also align with the Global Fund priorities, working with AGYWs, strengthening health system with having this gender lens, and also advocating for community-led monitoring for HIV services, and also to identify FGS as part of HIV services. Next, please. Women for Global Fund has also developed a guide on how to engage within the CCM, which is the country coordinating mechanism of the Global Fund. So this document can help women advocates to really understand the CCM dynamics, to build alliances in CCM, and really strategically push for FGS to be prioritized in the Global Fund grants. We have national focal points in each country, and we'll also have flourishers group that are sometimes new members of the CCMs and don't know how to navigate it. They don't know how to advocate within the CCM. So I think this is a tool that you can disseminate among your partners and networks, especially women-led networks, to really identify key decision makers and entry points to introduce FGS as a critical health issues in your country, to really try to form coalitions, to amplify advocacy efforts, and to discuss, the budget allocated to different, to HIV and FGS, and to make sure that FGS is receiving sufficient resources within the HIV response. And the CCM guide is also available on our website. Next, please. So, I'm just putting here some resources, additional resources that we have put in our website, so you can really navigate the Global Fund process and know how you can really ensure, strategic advocacy with stakeholders. And we will put more resources on FGS, very soon. So you can just check our website to make sure you have access to this information. Next, please. Our key advocacy points as Women for Global Fund regarding FGS is mainly to position FGS as a neglected SRHR and HIV risk factor. Second is to really push for its inclusion in the Global Fund funding request under the HIV modules and SRHR modules, and to emphasize the sustainable integration of FGS services into the current existing programs. And you can advocate for these key points by using some strategic tools, which are the gender assessment and program evaluation, and also country case studies on the successful integration of FGS and in SRHR services like in Malawi. So we can use these case studies to really advocate for other countries. Next, please. So final slide is that we are calling all women advocates to, play a critical role in ensuring that FGS is not overlooked in funding discussions, especially with the age replenishment now. I know that, we have some challenging time and the funding is decreasing, but we need to really advocate for the inclusion of FGS in national strategic plans and in the HIV response framework. And through the CCMs, through the Global Fund processes, we can push for stronger integrations and better funding, and to have a more holistic approach to women's health. Thank you so much.
Thank you so much. And I know already, okay, great. You can follow the Global Fund for Women, Women for Global Fund, sorry. And those are their social media QR codes that you can scan. So do feel free to also, follow them and follow ENASO at ENASO. And I like the conversations, and what I appreciate is the fact that a lot of people are relating to the discussion and they're having those aha moments or want more information. And Simon, I'll just bring you back real quick because I've seen a question on the chat. And looks like everybody's impressed. Most people are impressed with what you're doing in Malawi. Hala says Malawi experience is a model for other African countries. Just a quick question, Simon. Do you have any sort of links to some of the work you're doing through the whole process of trying to convince, and get the guidelines edited and FGS incorporated? Are there any sort of data you can share with people on the group? And ladies and gentlemen, we have the poll still ongoing. This is the second round of questions. Please feel free to answer the poll that's on your screen. But Simon, if you would share a little bit of insight on that. And Richard, we can go to the next slide.
Thank you, Lizzie. Yes, we have reports and processes that we have followed to get to where we are. And I think at some point I can share some of those processes. I think what we'll do is, because we haven't updated yet our website, but I think I can share a link where people can access all the reports and what it took for Malawi to get to where we are. Thank you.
Thank you, Simon. Dr. Gamba, there's a question around the same FGS being done in the coastal province in Kenya and trying to integrate FGS and antenatal care. Are there any other countries that have done this? Any best to your knowledge, but also just to give us like a background on Kenya itself.
Wow, thank you for that question. Well, there are several things we've managed to do. Of course, I can talk more confidently about what we do in Kenya, but then, okay, regionally, in terms of just trying to integrate, I think that has still been an issue in most of the countries. FGS is normally done in research settings. So what we've tried to do also differently and trying to borrow from what Malawi has done is mainly just identifying that these are women and girls, because no one comes with FGS written on their face. So these are women and girls in endemic areas. And what we've tried to do is that all service points that offer treatment for this women or any services, whether it's family planning, whether it's vaccination, whether you're doing HIV clinic, whether you're coming, for your normal outpatient visit. So we've tried to incorporate all the practitioners in this service delivery point so that they are aware about FGS. They know actually how to screen for FGS, and they even know the actual treatment for FGS. And even further, using the communities now, we even use them as, key points for just creating demand from the communities to actually say, if either you have this and this symptoms, you should go to these facilities where they'll offer you integrated screening for FGS and also a plus for cervical cancer. So we always do that together. And of course, based on the symptoms that we've talked about, the discharges, then STI becomes a proxy, so they're given the wholesome treatment for it. Yeah. I hope that answers you.
Yeah.
Oh, yes. And this is definitely through the work with the LVCT health team and the Ministry of Health. They've been quite helpful in this integration. Thank you.
Yeah, that's great to hear. Yeah, because I know, and I think this came out from Alia's and Simon's feedback. Collaboration is actually key in actually addressing this. Barushimana, you can actually unmute yourself and ask your question. Ladies and gentlemen, we're on the Q&A segment of it. We have approximately 16 minutes to go, and the 16 minutes are dedicated to you so that you can let us know whether there are any burning questions that you have. Next slide, Richard, that we can address while we're here. But yes, I've seen the question around access to the slides, and we're going to do that. We're going to share the slides as soon as we're done. Barushimana, if you can just unmute yourself and ask your question, that would be awesome. Okay, I think Barushimana is not in a position to do that. But just to bring in the FIG team back, Yael and Leora, is there any organization that supports youth, especially in funding FGS programs in Africa? And I know also Alia might have some insight on this.
Thanks, Lizzie. So I think Simon already mentioned that there is a potential, there is a new program supported by the government of Germany under their new FGS initiative. I think that's still being developed, and so we don't have figures for that, but they also have a kind of global advocacy element to that initiative. But maybe I'll pass on to Leora to talk about what's happening in Kenya, and that will also respond to Martin Coleman's question in the chat.
Great, thanks.
So there's a significant amount of work happening in a number of countries, but all in a different way. Kenya is a specific example where FGS has been integrated into SRH services. Dr. Victoria Gamba has supported that work, and there are other colleagues on the call from an organization called LVCT Health that have been doing specific work in Kenya, where FGS has been integrated into SRHR services. So, for example, your peer education that you would do for family planning or sexual and reproductive health or HIV prevention, FGS has been integrated into that. And then similarly, oh, sorry, I can't say that, but I've tongue twisted. But as you then move into the clinical services for SRH, FGS screenings and diagnosis and treatment have been integrated. And if you want more information, we can definitely, Lizzie, perhaps see if we can do a specific webinar, maybe on Kenya, because I think that we need to go into the detail of how it's done. But there's also a lot of countries that Unlimit Health and Anouk will be able to speak to, which have been integrating services on FGS through the NTD side, which still, collaborates and integrates with the sexual and reproductive health services, but it's been done from the side of the NTD program. Similarly to how Malawi, in some ways, the entry was the NTD work, which then led to the STI. In inclusion in the guidelines. Some of those countries are Côte d'Ivoire, Madagascar, Ghana, and we've also got colleagues from Nigeria on the call that have been doing a lot of FGS work. So I guess, Lizzie, I think if there's interest from people in the webinar, we could definitely go into detail and do more webinars and meetings related to specific countries to show how it's done. Just to say also that there isn't one model that fits all. It depends on the country. Simon gave you an idea of how the advocacy in Malawi started, and how the engagement with NTDs and SRH and HIV sort of came together for the STI guidelines. In Kenya, it's been done similarly, and the entrance point has been SRH programming. But in other countries, the entrance point has also been different. So I hope that that's answered some of the questions, but we would definitely need to engage further. And it would be great to hear from people in the webinar if that's something they're interested in hearing, sort of country case studies.
Yeah, that would be awesome. Just like, because this is all global and we're taking a lot of different experiences from a lot of countries. But I've also seen there's a question around conflict affected areas like South Sudan. Is anything being done on those particular areas that FIG might know of?
Yeah, I'm not sure how much we can say. Obviously, when conflict erupts, that disrupts pretty much all government-led programs. But as Anouk has put her camera on, I think she might have an update. Thank you.
Yes, thank you so much. And the question is excellent because it is hugely important. And I believe it's from somebody who advocates quite a lot, Hala Taha, advocates quite a lot about, right, what do we do about conflict areas, but also just areas of large population movement. There's a lot happening at the same time as these disease issues. And what I can say, I can't give a particular example that we have, but I know that there are groups who are interested and looking at how to address FGS through the work that they do in conflict areas. A group which is interested and is looking to see and potentially doing a little bit of work in this area is MSF, Médecins Sans Frontières. So we do know that there are people there who are looking at how to address FGS in those services that they give in areas that are undergoing conflict or emergency response, where the women coming to their services are affected by a huge range of things. So that is, but a lot more I think could be done in this area, and it's all about how do we bring in something like FGS into those services so that it is perhaps addressing a missing piece of the that comprehensive, equitable, and high quality health service package, and addressing the needs of those women and girls. So thank you, Hala, for asking that question. It's really important to remind ourselves about that.
Definitely.
Yeah.
Great. And thank you, Pile. Yes, for sure, more engagement is needed. Please, with country-specific case studies, FGS is such a complex entity. So it looks like there might be a reason for us to have now country-specific FGS discussions, and we're more than happy to help facilitate that. So please feel free to reach out. I will request the speakers also to just share their email addresses if the attendees would want to reach out directly, or you're more than happy to reach out to Ian. So we'll also leave a email address there so that you can reach out directly to the team. I know we have 8 more minutes. I've gone through the questions and we've actually addressed all the questions in the Q&A. I'd like to just bring in the speakers who were there, and we'll actually start backwards and just see, because we have eight minutes that we hadn't anticipated for, in terms of possible future engagements, ongoing maintenance on and information that we're having and call for collaboration, what would be that one parting shot? Because I was hoping that our ED would be here, but he's not here, so we can use this time just to do like a parting shot and call to action. But clearly FGS is an issue. A lot of countries do not know about it, and we've understood that it's because of lack of knowledge. What would be your parting shot as we start closing down the webinar? So I'll go to Dr. Anne.
Parting shot. I think that working together, because as we've said, that the global funding landscape is changing so rapidly, and things are becoming harder. But also just recognizing that siloed approaches to disease doesn't address the need of the person that comes for help. So we need to think about how do we work together to make sure that the service we are providing and the prevention services that we can provide, so stopping girls from developing FGS, how can we ensure that that is integrated, it's reaching everybody that we want to reach? And this is really something where advocacy champions is what we need from people on the ground and who have that knowledge in the countries that are experiencing FGS and a whole range of health issues. Thank you.
Great. Thank you very much for that. Yeah, Leora, you guys are doing quite an amazing work around this point. So maybe just talking about what are the next steps, areas of engagement, etc. It will be good to hear from you before we go to Dr. Gamba. Thank you very much. My ED is here. Hey, Roderick. Lovely having you. Love the background, though. I need to update mine. But Leora, over to you then, Yale.
I think FIG is really working to try and increase awareness around FGS and ensure that all the sectors related to FGS work together and work collaboratively. As Anouk highlighted, we can't have siloed approaches. It's not going to work. And I think FGS is really a clear marker around how healthcare systems really are failing women and girls. And we really need people to stand up and speak about FGS, try and educate anyone they know, tell anyone about FGS, and really get out into communities and make communities aware of FGS. Similarly to how the HIV movement really began in the 90s and that strong community activist approach took hold. We are really trying to bring that about around FGS because we cannot continue to leave women and girls without these services, and we cannot continue to ignore the risk that it places. And as we move into a different era of, funding and a different sort of global health infrastructure, we really need to not keep quiet about the need for integration and not let the funding issues affect our advocacy, because only through integration are we ever going to address all of the risks that young women and girls are facing and really, give them quality healthcare. Yael?
Thanks, Leora. I don't have much to add, but maybe if I could just focus everyone on the I in the FIG. What we're advocating for is integration. It's integrated quality healthcare services for women and girls that support their health and well-being. So I know that we're using a very specific lens, but that is the outcome that we're looking for. So we're all going to come across pushback from people saying, well, there's so many more urgent issues to focus on. Why should we also care about FGS? So if anyone asks you that, this is your answer. We're not just trying to raise awareness about a specific issue. It's about the health and well-being of women and girls. And FGS is a useful lens.
Great. Thanks, Joe, for that. We'll go to Dr. Gamba, then Simon, and of course, Alia, before we hand it over to Roderick.
Thank you for that. Yes, I think a lot has been said, and it's mostly about integration. What I would want to do is just to bring you back to the woman and putting her at the center, and just realizing that their needs are very different, and we need to focus a bit more on what they're telling us. So in emergencies or even in acute response kind of treatment, we always say you look, listen, and feel. So now, are you looking at the woman? Are you looking beyond the disease that she's presenting with? Are you listening to what she's saying in terms of she could be very stressed? Are you even trying to feel what this woman is going through? So once you're able to put all your senses in place, I think integration is a must, because you can't quite say you're just a tooth doctor. You have to still listen, you know. And even if you don't have to do that, if you're a dentist, you have to refer her to the next step. So what we are saying is, once you realize there's a problem, if you can't do it, make sure that woman is sent to the right place and given the comprehensive services. Thank you.
Definitely, definitely. Simon, looks like Malawi is on the limelight. I mean, you're doing quite an amazing work. We want to copy paste. If this succeeds and you get the guidelines revised, that will be a big kudos to you, and we'd want to keep close eye on that. So what would be your parting shot?
For me, really, I think I will talk about the need and importance of evidence, because I think the evidence that we submitted to the policymakers made a lot of sense and gave us the headway to make sure that the STI guidelines includes FGS. The other thing is collaboration and coordination, because that time the NTD department and the Department of HIV were working in silos, but we brought them together, and then they started looking at FGS and HIV as conditions that can be addressed in an integrated manner. And then finally, it's about ensuring that we've got strong voices from CSOs. And I think for Malawi, it helped a lot because it was a voice of the CSOs where they have a coalition that work together. And in all the consultations that we're making with policymakers, the researchers, gynecologists, it was CSOs who was coming to say, this is an issue. And just to echo what Dr. Gamba said, sometimes it was worrisome to see that some women are giving a deaf eye to FGS without thinking about the vulnerable woman who is in the village and suffering from FGS. And then some main policymakers making decisions on behalf of a woman who they don't see, but she is suffering out there in the village. So I think sometimes when you look at these things, let's look at who is suffering and why must we take urgent action and maybe pay attention to the evidence that we have. Because one challenge that we have, which is still there, is there's still some who say we still want to see evidence on the link between HIV and FGS. I don't know how much evidence they want, but the evidence is out there. Thank you.
It's a good way of putting it. How much evidence do we need to give you for you to get convinced? Alia, over to you.
Thank you so much, Gigi. I think the colleagues have said everything, but I join them, I mean, in saying that we need really to train and inform women advocates so that they can have really this important role in integrating FGS. And we need to actually think about sustainable funding for FGS programs and how we can integrate it in HIV programs. And finally, it's all about working together, creating strategic partnerships and breaking the silence about FGS and making it more visible to communities.
For sure. I totally agree and concur with all the sentiments that have been in. I know, Simon, you had mentioned that you're the only man in the room. It's because our acting executive director had not logged in yet, but he's here, which is good. So he always supports anything health related, especially when it comes to women and young girls. So he's here. He's going to give us his closing remarks. I know we are already 2 minutes past the due time, but Roderick, over to you so that we can close out the meeting. Thank you.
Thank you, Liz, and thank you all the speakers. Sorry for, of course, I was there, I was listening, though I had multiple calls going at the same time. So, but I did listen, and especially I was so much interested in the Malawi case, and I remember I was part of when they were doing the grant, I think it was grant making, where I did participate in Malawi, the HIV TB and STI strategic plan. I think that by then it was being revised, and there were lots of issues that were not being included, and there was opportunity to create an addendum to the NSP so that it can cover the issues that were not included. But just to mention that, of course, for me personally, it's my first time that just to get first, though I know the preparation of this webinar, I've been seeing this word FGS, but I think really get deep diving into the discussions. Today is my first time I'm hearing this, and I think it could be many of us we have not really had prioritized this, and I think this calls for an emergency to ensure that it's part of our programming. Maybe my call to all the participants, I think I know most of the countries, especially in our region, the Anglophone Africa, either this year or next year, they'll be developing new strategic plans. And it provides us with opportunities for us to provide inputs into an NSP. And we know that Global Fund, normally they will come and say their funding is tailored to the NSP. And so I think we should take that opportunity to ensure that FGS is included in part of the NSP development, and it is integrated into the HIV programming. And this one will help us in terms of tapping into the Global Fund resources, but also into in-country resources that may arise so that these issues are addressed. Also, buying from earlier presentation that there's a guidance for CCM and all the tools. I think maybe could share with us, we could disseminate widely. It could provide some more guidance, but I think I was also thinking maybe we could also do maybe some community guide, specifically for FGS, just to provide more information and guidance on how civil society can influence its integration into the national health agenda. I don't have much to say, so many things have been said, but I would like to take the opportunity to thank you for your participation. The webinar was very interactive, very comprehensive, and informative, and we hope we'll have more discussions like this as we go, so that to ensure that civil society and communities have the information to be able to influence the decision and do advocacy to ensure FGS is part of the health programming. Thank you, and we wish you a good day.
Thank you, ladies and gentlemen. Do have a great afternoon, great evening, great morning. We appreciate it, and keep an eye out on further FGS discussions from the team and the partners that have joined. Appreciate it. Have a great afternoon. Bye.
Thank you. Thank you so much, Lizzie.
Bye.
Thank you.
Thanks, Lizzie.
Bye. Thank you.